Good morning, good afternoon, or good evening, wherever you are logging in from. Welcome to the September issue of the Australasian Pleural Seminars. We are very honored today to have Professor Koegelenberg from Cape Town, who is waking up early, especially to join us today. Coenie is a very experienced pleural specialist. I'm sure many of you will have read many of his publications, especially on interventional pleural procedures. So he will be one of the best people in the world to talk to us about ultrasound-guided pleural procedures. What a pulmonologist can do, not just what an interventional radiologist can do. And I think it is a very important skill these days, since the advent of the ultrasound-guided biopsy, at least our center, and I think around the world, all the experts, medical thoracoscopies has done a lot less of medical thoracoscopy, and where I talked to Philippe Estou in France, Alain Tremblay in Canada, Fabian in Vanderbilt, we've all done a lot less pleuroscopy now in favor of using ultrasound-guided biopsy. But in many parts of the world, this is still not a very commonly taught procedure. So Coenie today is going to give us a lot of practical hints. Now, just to remind everybody, if you got any questions, please type it on chat as we go along. And let's us welcome Coenie. And without further ado, we'll love to hear his talk. I was just commenting that his opening slide is already one of the prettiest we have seen in TAPS. So we look forward to the rest of the talk. Thank you, Coenie.
Well, thank you very much, Gary, for that very kind introduction. Now, for some reason, my slides doesn't want to. Now, I'm not even going to talk much about ultrasound. I think we all know it's become sexy. Now, when I first started, and I'm going to slightly veer off my slides, that Toshiba on the left there was the smallest ultrasound that we had. It's about 25 years old now. And a lot of my early work was done with that ultrasound machine. Now, as you all know, ultrasound machines have become very sexy. And the top right-hand corner there is my newest edition. I bought it myself for a measly sum of, apologies, a measly sum, I think, now, let me just block all the people out. It's the equivalent of 7,000 Aus dollars. That's a Butterfly, and I'm sure there are many other mobile ultrasound devices these days that you can connect to a tablet. And the software, the nice thing about this is the software is all in a tablet, so you save a lot of money. And the ultrasound probe no longer contains crystals. It's actually a very new and sexy technology. And to make it even sexier, it's got artificial intelligence. And if you can even do for me as a non-cardiologist, I can now even do a point of care echo with some assistance from artificial intelligence. So I'm not going to convince you to use ultrasound if you've not been using it. I've been using it since it wasn't sexy. Now it is sexy. So I'm going to start my talk specifically very practical for those of you who may not be familiar with ultrasound-guided procedures. And I always say, look at all the imaging before you start. So when you may have a busy theater slate or whatever, and you've got how many books, take your time, familiarize yourself with the patient, and look at everything. Now, if this was your patient, and you may think, well, this is very easy. It's a large effusion on the right. You know, it's going to be, I may even do it with ultrasound. But this was actually the scan of the same patient, and you'll see there was only a sliver of an ultrasound, of a pleural effusion present. So look at all the information at hand before you start the procedure. Then safety is paramount. And once you've positioned your patient, and I'll talk to positioning, it's important to make sure you identify all the main viscera. You don't want to stick something in the liver if you don't need to. If you have the capacity, you can use Doppler to identify the intercostal arteries. Now, I don't do this routinely, but in elderly patients, the intercostal arteries can become ectatic and particularly close to the spine, and you may inadvertently biopsy an intercostal artery. So it is something that you can do if you have the ability and you think this is a high-risk case. Now, that video playing in the background there essentially tells you, or the point I'm trying to make, there are two ways of image-assisted ultrasound biopsies. We do mostly the so-called freehand technique, and that is we position the patient in a very specific position. We often prop them up or put them in a chair if needed, and without them moving, we very accurately identify the area that we're going to biopsy. And then we would measure the depth very accurately. And also, I can't emphasize the importance of going in the same plane. So the plane that you're going to use to do the biopsy, and this is now this is not a, well, it is a semi-pleural biopsy, but that's actually a lung mass. You have to stick to the same plane, depth, and safety range. So you've identified how deep you're going to go. In this case, 6 centimeters, not beyond 6 centimeters. And then you have to perform the procedure without the patient moving. And if the patient, for example, short of breath, you may ask them to hold their breath for a split second while you're doing it. So it is very important not to change anything while you're doing a freehand technique. So this is not real-time ultrasound. This is another example of a man who had unfortunately had lung cancer, and as you possibly can see on the scan there, it was close to invading his spinal cord. So this was quite an urgent procedure that we needed to do. And the best way of positioning was like that. And the person performing the ultrasound, again, this is not real time, this is freehand, will then identify the angle. And what I'm trying to show there on the left is up and down a bit, left and right, to make sure that you're exactly in the same angle that you are going to be doing the procedure. You then obviously mark the skin. I'm not going to discuss how to anesthetize and clean the skin, but we can take some questions in the end if anybody's interested. There are more than one way of doing this. Then you're going to perform and this is obviously a needle aspiration in exactly the same plane that you have identified. So you're not going to now suddenly go a few degrees to the left or right or wherever. You're going to go in the same position and perform your fine needle aspiration. Now, in our unit, we're fairly fortunate in that we have rapid on-site evaluation by a pathologist who will immediately tell you within 2 minutes, yes, you've got very good cells. It's probably a non-small cell lung cancer. And then if we need more cells for any targeted therapy, we'll do many cell blocks so that they can do the EGFR testing, etc. Now, this is another example. This is a two-cut biopsy, which I did a few years ago. And you may think I'm slightly crazy. It's obviously close to the heart. But if you stick to your plane and if you identify the major vessels and the direction, and because I didn't do it real time, I had to draw that arrow there. You have to make sure you're going obviously away from the major vessels, but you want to stay inside the mass. And this lady, unfortunately, had lymphoma, or fortunately, it was curable. Now, when it comes to pleural biopsies, and when you're using cutting needle biopsy specifically, it is extremely important if you're using this so-called freehand technique to measure the depth very accurately. Now, you can see there from A to B was 2.32 centimeters, and from B was 167 centimeters. So there are two ways. I prefer the straight line, and the straight line I just drew next to it because I didn't want to cover the dotted line, but I would do it exactly where the dotted line is. And I would know that on a true cut, and I'll show you a few true cut needles, there are centimeter markings. So I have to go in approximately, let's say 1.3 centimeters. And then I would use a true cut needle with a 1 centimeter cutting ability. I'm sure you know you get 1 and 2 centimeters to perform the biopsy and get enough little worms back. There is another technique, the dashed line there, and this was described by McLeod, I should say, many years ago, where he did it without ultrasound, where once he was through the Pleural, he swung the needle by about 45 degrees and then performed a cutting needle biopsy. I'm not advocating this technique. I'm just telling you that some people will use it even after they've measured, just to get a safer, or for them, a safer pleural biopsy, although I don't think it is safer myself. Now, I don't know, Gary, we can talk in the end if you still know how to do an Abrams needle biopsy. And if Jane Shaw does join your unit, she'll tell you, she can teach you in 2 days. The Abrams needle comes from 1952, and it's essentially made of 3 different components. There's the outer cylinder, and that the important thing is that blue arrow shows you the specimen notch, and the indicator tells you in which direction you're pointing. The inner stellate is like a guillotine that's going to cut that biopsy, and the stellate is just to keep water from pouring out, or pleural fluid from pouring out. Positioning is always paramount. I sometimes give people very mild sedation, and it should really be, and we can talk about it at the end. I get very upset when I hear one of my fellows doing a biopsy and I hear pain. It should be a painless procedure, this, with minimal anxiety. You can see there on the right, some, when they go in, want to, just to, as an extra safety measure, use a syringe to make sure they are actually inside the effusion and everything is fine. Then the important thing comes with an Abrams needle is to point it downwards. So you always go infralateral and not upwards, which is the obvious thing because you don't want to biopsy the bronchovascular bundle. And it is like a guillotine. As you've got your little notch there that tells you this is the direction I'm biopsying in, and then you turn the inner, the middle, if I could put it that way, to make sure that you have that guillotine action where you cut. So what I would normally do is I would pull it back until I feel something grabbing pleura, and then I would perform the guillotine biopsy, and that's a nice example of a pleural biopsy on the right there. Real time is a different story, and some people, when they don't like it, I prefer the time ultrasound assisted and clump them all into one. But if you want to purely talk about real-time pleural or real-time ultrasound assisted biopsies, it's a lot like an EBUS for those of you who can perform an EBUS. And let me just try and see if I can get this video to play. So there you can see it's a mediastinal mass very close to the aortic arch there. And you can see the needle going in and out very safely. I've played this in a few audiences, but really it is very safe. If you do it on the real time, you know you're not close to the major blood vessels. I was pointing towards the major blood vessels, but under real-time ultrasound, I could guide this biopsy and make sure that I'm not in the vessels. And this is a pleural biopsy. Now, the reason it appears round on the right and obviously not round on the left, it's just because of the angle at which you're performing the biopsy. So this was a two-cut biopsy performed real time of a pleural base mass. And you can see the needle going in safely, not in the lung, no complications. This is another example of a patient who had a recurrence of lymphoma. The middle slide, you can see the needle going into the mass, and on the extreme right at the bottom, you can see the 2 centimeter pleural biopsy that confirmed the diagnosis of lymphoma. You can do it in an in-plane, or out-of-plane technique, sorry, where you will only see the tip of the needle. I don't often do this because I find it actually very unhelpful. There may be people who completely disagree with me, but I find this technique very unhelpful. And in the end, it's the ultrasound is obviously very useful to exclude a pneumothorax, as we all know, and I'm not going to go into the signs of a pneumothorax. I'm sure you all know this. So what evidence do we have to back up the crazy things I've just said? Now, we performed a study many years ago where we looked at mediastinal masses. And these people would have, at the time, all gone for mediastinoscopy. And what we, in essence, did, and I'm not going to go through all of this, but we performed an ultrasound-guided fine needle aspiration with ROSE, or rapid on-site evaluation, and if non-diagnostic, we did a two-cut biopsy, and we could diagnose 93% of these patients with their anterior mediastinal masses. So what about pulmonary masses? The combined yield, if you follow the same approach, is almost 90%, and the fine needle aspiration has a higher sensitivity than cutting needle biopsy if you are talking about lung cancer or epithelial cancers of the lung. But if you talk about other conditions, benign biopsy, then the cutting needle biopsy is better. And it's been shown if you have a 3 millimeter or a 3 centimeter interface, your yield will be higher. Of note, if you compare ultrasound with CT in terms of accuracy, they are the same, but you save time with the ultrasound and you have statistically less pneumothoraces if you're using ultrasound. Not going to talk a lot about this, but you can use your ultrasound fantastically well in needling lymph nodes and bony metastases, which we often do. Which needle is the best? Well, it depends on the situation. But if you were enrolling patients with minimal pleural thickening, as we did in this study, because this was a study looking at TB, you were more likely to firstly have pleural tissue on your sample, and secondly, make a diagnosis of TB with an Abrams needle compared to a true-cut needle. It was non-statistic. I mean, the numbers for the alternative diagnoses were too small to compare, but it at least suggested the Abrams were just as good as the two-cut biopsy. Now, a group of Italians and Nash wrote a systemic review a few years ago, and fairly recently actually, and they did mention that obviously all of these studies were very heterogeneous because some enrolled TB patients like we did, some enrolled any. Some of our studies we enrolled all undiagnosed pleural effusions. 4 of the 26 studies that they identified were actually done at our institution. And the overall yield, and this is now, personally, our yield is slightly better, was 84%, and you can look at the confidence interval, and for CT was 93%. But what was for me very interesting is that if you look over time, we are getting better. One of the p-values, significant p-values, is that if you look at more recent studies compared to the older studies, there was a significant increase in yield, but the CT did not change. So there was no change in CT. It's always been the same. Complication rate in ultrasound-guided was significantly lower than any complications than in CT-guided, and serious complications, which I didn't mention there, was 1% versus 4%. In this study, it had a higher yield for malignancy than for TB, although in our work, it's the other way around. So how we approach, and I'm almost done, pleural biopsies with ultrasound is we stratify the patients according to imaging. And this is work Andreas Diakon and I have done over many years, but we've now validated this, is that you either sit with an overt pleural base mass, or you sit with diffuse or pleural thickening or nodularity, or you have a very pleura that has no thickening or nodularity. In the cases where you have a pleural-based mass, we would suggest doing a transthoracic fine needle aspiration, ultrasound-guided, obviously, with your rapid on-site evaluation, and if negative, perform a core needle biopsy. If there's diffuse pleural thickening, we look at how thick the pleura is. And now 1 centimeter is arbitrary. I mean, you can decide. It's obviously not a set in stone, but if it's less than 1 centimeter, we would rather use an Abrams needle and aim at the region of interest, obviously. And if it's more than 1 centimeter, like the example I showed you, we would rather use a cutting needle biopsy. What is important, if there's no pleural thickening, we would suggest using an Abrams needle because you're more likely to harvest pleura, and to go as low as possible because most malignant deposits are quite lower down in the costophrenic angles. If you have a diagnosis, you have definitive management. If it's non-diagnostic, if you live in a resource-constrained setting, it may be worthwhile repeating the imaging. So if you did not have a CT scan, get a CT scan or a PET CT or whatever. And if you live in a more, like in Australia, of course, you'll do a thoracoscopy or pleuroscopy, as Gary said, not to offend the surgeons. You can potentially perform VATS or a surgical biopsy. Now, this is a busy slide, and please don't try and look at the numbers, but we prospectively tested this and published it in Thorax in 2015. And we were able to, and these were undiagnosed pleural exudates. And in 90% of the cases, we were able to make a diagnosis prior to a medical thoracoscopy or pleuroscopy. So if you want to, I'm leaving you with 3 slides. If you wish to read more, this is the review I refer to, the systemic review on a meta-analysis on image-assisted or image-guided pleural biopsies, CT versus ultrasound. There's a chapter that's very practical. We really, in a very practical way, describe the techniques, the angles, how to position the patient, the local anesthesia. There's your reference. And then I'm not sure, perhaps Gary can tell me when the textbook of pleural disease, 4th edition, will come out. But there will be a chapter in there on image-guided pleural, guided closed pleural biopsies. And there as well, we really try to summarize it and make it as practical as possible. Thank you very much.
Great. Thank you, Coenie. That's a very comprehensive talk covering a lot of grounds. Just encouraging the audience, if you have any questions, please put it on chat and we'll read it out for you. Just to reassure Coenie that I have enough gray hairs, that I have done lots and lots of Abrams biopsies in my days and still do that for diffuse pleural diseases. And we got a couple of other colleagues who are very comfortable with it. So we certainly do that. And I'm glad to hear that you're also giving sedations. I think in my younger days, we never did. And I think we all progressed to a slightly more patient-oriented level. Now, let me just ask you, for the younger people in the audience who are not doing it at the moment, how would you recommend them to start? Pick the largest, most obvious one and pick the needles?
Yeah, I would say so.
Yeah.
Say so. And I'm very pro, as you said, it must be a pain-free procedure. There are essentially two ways, and Jane Shaw and I have different techniques. I tend to anesthetize the site and go out of I'm going to stop sharing my slides because I don't think there's anything more to share. Or am I sharing? Sorry,
You're sharing, but we can also see you, so not a problem.
Okay, so I tend to do around the site and the periosteum above, below, the pleura, and obviously the skin. Jane Shaw, for example, would rather do a block where she would block the whole the whole neurovascular bundle essentially, and to me it both works well. And then as far as sedation is concerned, I often would give 1 milligram of midazolam or something, and if needed, some fentanyl or rapifen or some short-acting opiate for pain and for just sedation, because the last thing you want, and you know this, is somebody to jump suddenly or change position, and then you almost have to start all over again because things have moved.
Yeah.
So I've learned, I would say the hard way, but let's call it the hard way, is and you can't always pick. I mean, sometimes there's big men come in and they look like they bodybuilders, and they're not gonna, they're not scared, and they flinch like babies. And other times you have little women who sit still and don't move. So you can't always judge your patient by looking at them and thinking this person is going to sit still.
That's correct. So would you recommend that they practice on models before they actually practice on real life people?
Look, I come from a generation where I've only practiced on humans.
Yeah. Okay.
Our medical school now has two. There's one for pre and one for postgraduate students, and they've got excessive amounts of I mean, you would be able to practice on a model.
Yeah.
I've never practiced a thoracoscopy or pleuroscopy on a model, or a pig for that matter. I have never done anything on anything but human, but that was when I trained. And they were the let's say the artificial or the dummy models were not up to scratch when I trained. I don't know about you.
Sure.
But it's an inherent thing because it looks dangerous, and I can understand why somebody would rather want to do a practice run. But I think if you have obviously you have to observe a few before you start, and then have an experienced hand next to you to say no. And the obvious important thing is don't biopsy like this, because then you're going to grab the neurovascular bundle, and that may not end up in a great outcome.
Right, it's a question online. In order to make sure that there's enough for your molecular testing these days, do you routinely do a core biopsy?
Yes,
for rows.
It depends. Unfortunately, we live in a country within a country, which I'm sure you're aware of. But where I have a patient that has access to medical insurance that will cover all these fancy new drugs, which are exceedingly expensive in our country. I'm not sure in Australia, but we would. But if you do a core biopsy of more than enough cells, if you do fine needle aspiration, like an EBUS, for example, which is now slightly off the topic, but if there's this magic 1,000 cells that they want to see, I'm sure you're familiar with 1,000 cells. And so what I would do if I only have a needle is I would do many cell blocks. So the cell blocks, they centrifuge them and they into a pellet, and then they essentially do the molecular testing on the pellet, and then they would actually comment on the adequacy of the sample. And I fortunately can tell you that more than 90% of the ones I do, they specifically comment it was adequate for molecular testing.
Sure.
But
Okay.
then you kind of like go almost overboard. You know you've got cancer, but you do 8 or whatever passes for the needle. Get as much into the cell block as you possibly can.
Yeah. Now, do you feel, how do you feel about people who've got no fluid for pleural biopsies?
I showed you many examples there. Did I not?
Yeah. So those are the lungs.
I'm very
for the
comfortable.
pleural biopsy.
But there you have to use the more I'd say more modern, but an ultrasound, and really measure the depth accurately to the millimeter. And if you feel uncomfortable, like many of my current fellows and consultants all do it real time. I'm still a bit old school, and I feel comfortable doing it image assisted, as I would say. So I've got in my mind the direction to the T. The important thing, and you know Andreas Diakon very well, which he taught me, is you can't measure in one direction and then do the biopsy in another direction. You must exactly be in the same plane. We would even measure the degrees at which we're going in. So to make sure that you actually, you can't measure something in one angle and then do it at another angle. So I feel comfortable, but the newer generation of fellows and consultants tend to feel more comfortable doing it real time. And we've got, I mean, we've got the ability to do it real time. It takes longer, and I'm just lazy and want to do it quicker. But if you want to do it real time, I showed you examples there, and do it real time.
Another question is, how about injecting normal saline intrapleurally when there's no fluid?
Never done that. Ever.
I think it will be very hard for whoever is asking the question, because the fluid will not stay in the same place. It will get dispersed. So to get you a 1 centimeter, 2 centimeter margin,
I think you
need a lot of fluid.
You should think differently and realize that if you measure accurately, you don't need that buffer of fluid. It feels nice if you know there's 5 centimeters of fluid, you know it's easier, safer. But if you do your measuring accurately, you don't need a buffer. And we do pleuroscopy, as you know, on people with no effusions, where we induce a pneumothorax, and I really don't think the absence of pleural fluid should put you off at all.
And for people who are getting higher and higher BMI, like our patients, any words of advice?
Yeah, that can be challenging. In extreme cases, I have, but fortunately I can count them probably on my hands. I have done a little incision, essentially, as safe as I possibly could, and then try and go deeper. Unfortunately, that is a realistic problem with the BMI. You try and go where it's the best, but sometimes, I have done it, I had to make a little incision, because the needle is 10 centimeter or whatever, and with extreme high BMIs, you may need to do we always joke a mini thoracotomy, but we're not doing really a mini thoracotomy. It's just a elliptical incision, so we can get closer to where we are seeing. That is true, unfortunately.
And other situations we often found is that if the patient has got a large pleural effusion, especially in a teaching institute, we do Abrams, and then the fellows need to do a few biopsies and so on and so forth. Then you form quite a significant tract, and then the fluid will keep leaking out. And so we ended up...
Sometimes I would put a little, just one suture in. Obviously, you can have tract metastases, and that's a separate discussion, but I sometimes would put in one suture just to prevent that from happening.
But the suture controls the fluid leaking out of the skin, but doesn't...
I know what you're saying. It doesn't really... Yeah, I try and use a hand, one of those, not a small little, one of those handheld needles, and try and go as deep as possible.
Yeah.
I hear what you're saying, but the hope is, at least if there's compression, because what I've not seen, fortunately, is a patient leaving the hospital with a massive seroma, or whatever you want to call it, collection of fluid.
We have, and that's why we sometimes are a little bit more cautious. Right. Now, you mentioned about intercostal artery. If you see it, you try to avoid it. If you don't see it, it's still there. It's just that you don't see it.
Yes, and I've had the misfortune of biopsying the odd one, and fortunately, compression does help. So if you can get into somehow the same space and compress the artery, it does help. I've never had to phone we have obviously a thoracic surgery backup, but I've never had to press that button and say, please come and bail me out. Yeah. That's weird. It may still happen. I don't know
how many cases do you think that your trainee needs to do before they will become independent?
Look, I think 20 is a thumbs up. We don't have actually a logbook when it comes to pleural biopsies where you, but some are so good, you see them do 5 and they fine, and others do 20 and they still can't do it. So it's like many medical procedures. Some are just quick to learn, and some just take much longer to learn. And it's a lot about confidence and fear, and to make them feel. I try to be as calm as possible when I'm in theatre, not shout. Patients also don't like it when there's a commotion in the background. So try and be calm. And
good. All right, I think we are quite over time. So let me thank Coenie again for excellent interaction on. And I'll invite you, everyone, to join us again in October, first Wednesday. Next time we'll have Professor Jeanette Coenie to talk about biomarkers of pleural diseases. And for whoever has missed the talks, they are all on YouTube. If you just put in TAPS and pleural, then you can see all of it. Thank you very much for joining us this month. Thank you.